So in this session, we'll be dealing with the second half of the anterabdominal wall. In this particular session, we'll be dealing with the rectus sheath, contents of the rectus sheath formation. Then we'll also deal with the surgical aspects of the anterabdominal wall. As you can see here, the central line in the abdomen, which divides the anterabdominal wall into two halves, is the linea alba, and you can see this is the umbilicus. Here you can see the linea semilunaris. So this is the linea semilunaris. So here you can see these are the 9 regions of the abdomen, as you see here. So this is the transpyloric plane and this is the transtubercular plane, and you can see here these are the vertical planes which are passing through the midinguinal point and also the midclavicular point. So by this two horizontal and two vertical planes, the entire abdomen has been divided into 9 regions. Namely, here you can see the epigastric region, this is the left hypochondrium and this is the right hypochondrium. This is the umbilical region, this will be the right lumbar and left lumbar region. And this will be the right iliac region, this will be the left iliac region, and this is the hypogastric region. So clinically, when pain is arising in this particular region, so we can correlate that pain with the particular viscera which are present in that region. So this is how this regional classification helps in identifying the viscera involved. So not always it will be the accurate one, but we can come to a preliminary location or preliminary idea about the organ which is involved when the patient describes pain is confined to particular region. Like if you see the pain is confined to the right hypochondriac region, so we can think about liver and gallbladder. If the pain is confined to the left hypochondriac region, so spleen will be present here. And if the pain is confined to the epigastric region, stomach will be present. If the pain is confined to the right lumbar and left lumbar, the kidneys and ureters are involved, like that. So here you can see the layers of the anterabdominal wall. You can see this is the skin, this is the campus fascia, which is fatty. Then this is carpus fascia, which is membranous. Here you can see the external oblique, internal oblique, transverse abdominis, fascia transversalis, extraperitoneal connective tissue, and peritoneum, parietal peritoneum especially. So if you see the posterior aspect of the anterabdominal wall, you can see here this is the median umbilical ligament, which is formed by the urachus, which is remnant of the allantoid diverticulum. Here you can see this is the medial umbilical ligament, so which is formed mainly by the obliterated umbilical artery. Here you can see the inferior epigastric artery, which forms the lateral umbilical fold. Between the median and medial, you can see this is the supravesical fossa. So lateral to the medial umbilical fold, you can see this is the medial inguinal fossa. Lateral to the lateral umbilical fold, you can see this will be the lateral inguinal fossa. So now coming to the rectus sheath, as you see here, this is an aponeurotic sheath which encloses the rectus abdominis. So it is having an anterior wall and a posterior wall. You can see here anterior wall is complete, but posterior wall is deficient below the arcade line. So this arcade line approximately corresponds midway between umbilicus and symphysis pubis. And here also above the costal margin, the posterior wall is deficient, whereas anterior wall is complete from above downwards, but its thickness varies. Above the costal margin, it is thin. From costal margin to arcade line, it is moderate, and below the arcade line, it is the thickest. Why? Because the three muscle aponeurosis, that is the transverse abdominis, internal oblique, and external oblique, all will pass anterior to the rectus abdominis. Posteriorly, nothing passes. So here, below the arcade line, fascia transversalis is thickened to form the iliopubic tract. You can also see the anterior wall of the rectus sheath is attached to the rectus abdominis with 3 indentations. One at the xiphoid, the other at the umbilicus, the other is midway between them. Whereas posterior wall of the rectus sheath is free from the rectus abdominis. Here you can see the inferior epigastric artery and superior epigastric artery. So you can see here, this is the rectus abdominis muscle. So let us see at different levels. Rectus sheath above the costal margin, you can see posteriorly it is deficient, whereas anteriorly you can see it is formed by the external oblique aponeurosis only. That is why it is thin. So if you see the rectus sheath between arcade line and costal margin, you can see here anteriorly there is external oblique aponeurosis and there is anterior lamina of the internal oblique. Posteriorly there is posterior lamina of internal oblique and transverse abdominis muscle. So when you come to the area below the arcade line, you can see posteriorly there is no aponeurosis passing, it is only the fascia transversalis, but anteriorly you can see the aponeurosis of the transverse abdominis, internal oblique, and external oblique. All the three, they make the thickest part of the anterior wall of the rectus sheath. You can see here inferior epigastric artery passing in front of the arcade line. This is the arcade line, this is the fascia transversalis, which thickens to form the iliopubic tract. So now you can see these are the linear decussation. This is the linea alba. So where there will be linear decussation, so all the aponeurosis from both the sides will cross, but especially between umbilicus and iliac crust, there are two decussations. One is in the mid-ventral line, the other is at the lateral margin of the rectus sheath. So this mid-ventral line decussation is formed by, you can see here, the anterior layer of the internal oblique will actually decussate with the both layers of the external oblique. So this is the mid-ventral decussation what we have observed here, this one. And if you see the lateral margin, the decussation, the lateral margin, you can see here that is due to the decussation of the posterior layer of the internal oblique with the transverse abdominis. Okay, so all these indicate that the aponeurosis of one side are in continuation with the aponeurosis of the opposite side, and they cross like X-like manner, so that to strengthen the anterior abdominal wall. Here also you can see, if you observe the lamina of the external oblique, the outer lamina direction and the inner lamina direction is almost perpendicular to each other. Same way, the aponeurosis of the internal oblique, transverse abdominis, everywhere there is opposite direction in the two lamina of the each muscle. So this is the bilaminar concept of the formation of rectus sheath. So this crossing X-like manner will actually help in strengthening the interabdominal wall. Contents of the rectus sheath. The muscles are rectus abdominis and pyramidalis. The vessels are inferior epigastric artery and superior epigastric artery. The nerves are lower 5 intercostal nerves and the subcostal nerve. The specific pattern is the nerves enter the rectus sheath by piercing the posterior lamina of the internal oblique in the posterior wall of the rectus sheath and supply the rectus muscle segmentally, pierce the anterior wall and become cutaneous. The subcostal nerve supplies the pyramidalis in addition to rectus muscle. So here you can see this is the rectus abdominis muscle, the medial head taking origin from the anterior surface of the pubic symphysis, whereas lateral head taking origin from the lateral aspect of the pubic crest and pubic tubercle. And the incision is by 4 fleshy slips, one to the xiphoid process, the other to the 5th, 6th, 7th costal cartilages. And the supply is by lower 5 intercostal nerves and the subcostal nerve. Action will be flexion of the vertebral column, the protection of the viscera, and compression of the compression of the abdominal cavity, and maintaining the tone of the abdominal muscles, maintaining the intra-abdominal pressure. So medial head from anterior surface of symphysis pubis, lateral head from pubic crest, that is the lateral part, and pubic tubercle. Insertion by 4 fleshy slips to the xiphoid process, 5, 6, 7 costal cartilages. The 3 tendinous intersections which I have shown in the earlier diagram, that is at the level of xiphoid, umbilicus, and midway between them. Nerve supply is by lower 5 intercostal nerves and subcostal nerve. Action is protection to the abdominal viscera, maintains intra-abdominal pressure and flexion of the vertebral column. Here you can see the pyramidalis muscle. So it takes origin from the symphysis pubis and the pubic crest. Insertion, so its apex is inserted into linea alba, midway between the umbilicus and symphysis pubis. Nerve supplies from subcostal nerve. It's a tensor of the linea alba, but the purpose of tension is not known. Peculiarities, sometimes the muscle is absent on one or both sides. You can see here. So these are the vessels. This is the inferior epigastric artery, which is a branch from the external iliac artery, and this is the superior epigastric artery, which is a terminal branch of the internal thoracic artery. Both are anastomosing here. Here you can see the 3 indentations by which the anterior wall of the rectus sheath is attached to the rectus abdominis. So these are long muscles. In order to increase the force of contraction, so these indentations will cut the long length muscle fibers into shorter length fibers, which have more powerful contraction. So here you can see the segmental nerve supply here, T7, T8, T9, T10. T10 is corresponding with the umbilicus, then 11, 12, L1. So any kind of tumors related to testis, ovary, and even the pain related to appendix, all are felt around the T10 because of the common segmental supply to those viscera. So here you can see this is the dorsal root, this is the ventral root, spinal nerve, this is the dorsal ramus, this is the ventral ramus. You can see the ventral ramus moving forward between the internal oblique and transverse abdominis. This is the lateral cutaneous branch, and here you can see it is piercing the posterior lamella of the internal oblique, then supplies the muscle, then pierces anterior wall of the rectus sheath, then becomes cutaneous. So this is a higher magnification picture where you can see this is the intercostal nerve piercing the posterior lamina of the internal oblique, then supplying the muscle, then piercing the anterior wall of rectus sheath and skin and becoming cutaneous. So here you can see the umbilicus acts as a watershed line. The lymphatics above it goes to the axial lymph nodes, below it goes to the superficial inguinal lymph nodes. You can see the veins here. So at the umbilicus there is paraumbilical vein, which is a portal component, and surrounding the umbilicus there are systemic components. You can see the superior epigastric vein, inferior epigastric vein, the lumbar veins, posterior intercostal veins. All these communicate with the portal vein at the umbilicus. When there is portal hypertension, there will be dilatation of the systemic channels, so which results in a condition called caput medicae. You can see the radiating dilated veins around the umbilicus. This is called caput medicae, which is in portal obstruction. There are other areas of portocaval anastomosis like anal canal, the diaphragm, the lower end of the esophagus. So all those areas, no, that we'll deal with the portaceval anastomosis in subsequent classes. So now we'll come to the surgical aspects. As you can see here, this is a single muscle supplied by a single nerve fiber. When you see the cut, so this nerve is damaged and the muscle is paralyzed. But when there is a segmental nerve supplied to the muscle, when we cut between the two nerve segments, so then there is no damage to the nerve, and the muscle's nerve supply remains intact, and there is no paralysis. Healing will be faster, recovery will be faster. So here you can see some common incisions like Cocker's incision, which is a subcostal incision. You can see upper midline incision, lower midline incision, supraumbilical and infraumbilical median incision or midline incision. You can see the paramedian incision. You can see the transverse incision. You can see the McBurney's incision or Guidarius incision. So here you can see the midline incision, where these are the layers which are cut: skin, linea alba, fascia transversalis, extraperitoneal fat, and peritoneum. In this kind of incision, there are more chances of incisional hernia because this linea alba is less vascular, and there will be always weak scar. So you can see here the midline incision is extended by a right angle extension through the rectus. Here you can also see the Rutherford-Morrison incision for difficult operations in the bile ducts. The B line, the dotted line, this is the Rutherford-Morrison's incision. So here you can see this is a supraumbilical incision, but you can see an additional incision extending from umbilicus to the tip of the 10th costal cartilage, so which will not damage the intercostal nerves. So here you can see there is a paramedian incision, but without damaging the rectus abdominis. You can see this rectus abdominis is being retracted and the surgery is being done, then the rectus abdominis is placed back, so that this actually strengthens the incision site. But here you can see the rectus abdominis is also cut. This is the muscle splitting incision. This is muscle retraction incision. This is muscle splitting incision. So here you can see the Mayer option incision. This is a paramedian incision. The upper end of it can be extended to the xiphoid process if it is necessary. This is Mayer option incision. So now coming to the abdominal hernia, inguinal hernia. So herniation through the inguinal canal. So we have a separate session on the inguinal region. So then we'll deal in detail with it. Femoral hernia is through the herniation of the contents through the femoral canal. So this also we deal when we are dealing with the femoral triangle. So now internal hernia, internally an organ protrudes through foramen or peritoneal fossa. So such a condition is called as internal hernia. Epigastric hernia is through wider part of the linea alba between xiphoid process and umbilicus. So hernia is basically defined as the protrusion of the contents through the walls which contain them. So epigastric hernia is the hernia which is occurring in the epigastric region. Where it is occurring, it is through the wider part of the linea alba between the xiphoid process and umbilicus. Divergation of the rectus abdominis. So here the hernial sac bulges forward between two recti. The rectus sheath of both sides is extensively stretched, seen in multiparous females. Umbilical hernia, it's of two types, congenital and acquired. Congenital umbilical hernia is also called exampholos or omphalocele, when physiologically herniated loop of midgut fails to return to abdomen due to persistence of extremogenic coelom. Then this also you will understand when we deal with the development of the gastrointestinal tract, especially the development of midgut. So then abdominal, congenital umbilical hernia is one thing. Then the next one with acquired umbilical hernia. In this again there are two types, infantile and adult. The infantile type is due to weakness of the umbilical scar. It subsides when abdominal muscles will differentiate with eventually. There is not much requirement of surgical intervention. But if you come to the adult, the hernia appears through linea alba by the side of the umbilicus, but not through the umbilicus. So especially adult umbilical hernia is not actually the umbilical hernia, it's a paraumbilical hernia. So it is coming through the linea wall, not through the umbilicus. Needs surgical correction because it becomes larger and larger. Spigelian hernia is occurring at the junction of arcate line in the linea similaris, and incisional hernia is midline incision through linea alba prone for herniation due to weak scar because of less vascularity of linea alba. So any incision can result in weak scar due to improper healing and can result in incisional hernia. So you can see this is the epigastric hernia. You can see this is the divergation of rectus abdominis. Thank you.